Welcome to Lipstick and Logic. We are episode 3, part 2, and we're in the menopausal patient, the perimenopausal patient. And let's talk about aesthetics. Talk to me a little bit about what can women do so they aesthetically look better and also feel better when they're going to menopause.
So we just submitted a paper with Mary Claire Haver, who's an OBGYN that focuses on menopause, and then Dr. Lindsay Pennington, who's a facial plastic surgeon that has a practice just like mine, but more surgical, that's really focusing on the perimenopausal and menopausal patient on aesthetic treatment considerations. Now, I think the women that benefit the most from our aesthetic treatments are the ones that are on some level of systemic HRT, because there's nothing more powerful than that fertilizer that you get from your hormones, right? The things that we do, whether it's a CO2 laser resurfacing procedure, that's probably going to be the most aggressive laser to stimulate and jumpstart that collagen and elastin production. That's great, and it'll do it, but it'll do it a lot more effectively if it has a little bit of hormones to fertilize those fibroblasts, which are the cells that create the collagen and elastin. So that's kind of how I like to explain to my patients. I can create, I can put the seeds to create that collagen and elastin, but the fertilizer is really important. And so I generally tell them to see a functional or integrative medicine doctor to kind of walk, or an OBGYN that focuses on hormone replacement, to get them on the right cocktail for them.
So you want them on the estrogens because they'll respond better to your aesthetic treatments.
I find now in practice that the women that are 60 but look like they've never been through menopause are the ones that were on HRT during menopause or started before.
Okay, but we got to bring up 2 other situations here, and that is women who are overweight or obese, their skin does not age as fast, doesn't look as, in my opinion.
Right.
And there's plenty of evidence that darker skin patients, thicker skin patients, Asian patients, African American, Black patients, their skin doesn't age as fast. And Hispanic patients does not age as fast. So what do you have to say to that?
Right. So that's a great point, and it actually just it highlights the story of hormones in the skin, right? And that is that fat becomes your secondary endocrine organ. So your ovaries were the primary organ creating that estrogen and progesterone. And then all of a sudden, as that declines, your fat becomes the major player. And so if you're very thin, you don't have a lot of subcutaneous fat, you're not really supplementing that hormonal drop as well. But there are studies that show that BMI, so how much body mass index you have, does inversely correlate with your wrinkles. And is it because that fat is stretching your skin and you don't have wrinkles? No, it's because that fat is creating that estrone and estradiol to supplement what the ovaries can no longer create.
So one of the reasons why when we see patients on the GLPs, like the Ozempics of the world, the Mounjaros, they seem to be aging faster in our opinions, and that might be losing some of that fat, almost like an induced perimenopause or induced menopause. I know you've talked about in the past, and losing those adipose-derived stem cells, and those stem cells are what create more fibroblasts and collagen and elastin and even fat itself.
Right, so you have these beautiful stem cells called adipocyte-derived stem cells. And so how much of it is age-related? Because we know those stem cells kind of weave through the dermis, the second layer of skin. And so as we age, that area becomes fibrotic or just kind of dies off, it's what we call kind of scar tissue. Whether it's related to extrinsic factors like UV light or pollution or age, there's definitely that element, right? And those stem cells diminish. But then we know that the hormones are like fertilizers for those stem cells because, again, they reside within fat. And so those stem cells are responsible for becoming the fibroblasts that create collagen, elastin, hyaluronic acid, and for creating fat, as well as for creating bone. They can morph into osteoblasts. And we know that as we age, our skull shrinks. I think Sebastian Cotofono showed like 200 by 250 cc's. Your skull shrinks when it's already in its 70s. So you're losing fat, bone, and your skin is getting thinner and less elastic.
Okay, but how do we explain the darker skin patients
So
and their skin not aging as fast?
right, and so that's the reason why those that have more fat, that's the physiologic response to why they don't show signs of aging as much, right? Because of that reservoir for estrogen. But in those that are more melanated skin types, whether of Asian, African, or Latin American descent, melanin does serve as kind of an umbrella for your fibroblasts. It protects them. It resides in the basal layer, the top layer of the skin, and so it's kind of like a nice little umbrella that protects that UV damage from penetrating and creating DNA damage to your cells. And so you don't get as much collagen and elastin breakdown. So the wear and tear on that skin is not as much. And so that's the reason why you don't see as much sign of age, 1. 2, those ethnicities generally also have more superficial subcutaneous fat. And so as a result, you also deceivingly don't show signs of symptoms of aging. So we've seen that those of Asian and Hispanic descent show signs of aging 10 years later than their Caucasian counterparts in a study that was published by Andrew Alexis. And those that are of African American descent show signs of aging as measured by wrinkles, usually 20 years later.
Minor to severe wrinkles.
Yeah.
And that's very interesting. And they have more sebum production too, I believe. Yeah.
Right. So they also have more apocrine and eccrine glands. Those glands that are generally regulated by some of the hormones, right? And so you can have other things. It's not just hormones. Again, this is a holistic approach, right? So hormones play a role, your genetics play a role, your level of melanation plays a role that comes from your, ethnic background. Even though our child should have more melanin because he's Moroccan and Hispanic, he doesn't. So it's not always a for sure or a given, but it's an interplay of a lot of things. But you can usually have a great understanding by looking at someone's skin as to what's going on.
So let's talk about treatment options.
Yep.
So you like the patients who are on HRTs because you think that's a fertilizer that gets them ready and they're going to get a better outcome from our aesthetic treatments. What aesthetic treatments what's your go-to at first when a patient comes in with they're aging to perimenopausal and they want to look better and taking into account all the layers of the skin and the subcutaneous tissues?
Right. So I love products that are biostimulators that can stimulate those adipocyte-derived stem cells to morph into the cells that we just talked about that are all diminishing with age. So for me, PLLA is one of them. We just showed in our practice that it doubles the amount of adipocyte-derived stem cells that are within tissue after 6 months after the last injection. So
that's a breakthrough study. I want to reiterate that because many people don't realize that. The fact that you were able to prove that adipose-derived stem cells are increased in quantity, is that right? And
after 3 sessions, 1 vial, 1 month apart, and then this increase was able to be captured 6 months after the last injection. That's not to say that those cells were actually not even greater at a different time point. We just didn't capture.
So these are progenitor cells. These are the beginning cells that then can differentiate or de-differentiate into fibroblasts or osteoblasts, your collagen, elastin, and these are critically important. And this may be the true mechanism of how we're improving the skin. It's not necessarily causing a stretch in the fibroblasts to create more collagen.
No.
It's these adipose-derived stem cells, and harnessing the power of those adipose-derived stem cells may be the real key to looking more youthful.
Right, because those cells, as we just talked about, it's all a perfect ratio, right? So those cells differentiate to create a little bit of fibroblasts so that your skin gets thicker, and that's what we saw. But we also saw the same amount of ratio in increase in subcutaneous fat. So then you have healthy fat that's supporting your skin, because your skin sits on healthy, what we call hypodermis or subcutaneous fat. And although we did not measure bone or the number of osteoblasts that came out of it, you would think that if it's differentiating into all 3 cells, that it potentially could do that as well. And we know that we're losing bone. That starts at 25, significant at 35. And then if you have a loss in collagen and a loss of estrogen, then you're going to also see a pretty big decline with that.
Now, to be fair, hyaluronic acid, also there's studies out there to prove that it can as well stimulate adipose-derived stem cells.
Correct.
Maybe not as robustly as some of these other biostimulators like PLA or dilute calcium hydroxyapatite, but is a benefit to HAs, even though we're seeing a decline in that. And we should do an episode on that as well too, right?
Right.
But we're seeing a decline in the amount of people desiring the HAs right now as compared to the biostimulators, where there's been an increase.
Right, the hyaluronic acid fillers we're seeing a decline in, but there is a role for those, especially the skin boosters, which you can inject more superficially where these adipose-derived stem cells reside, which is not the case for all HHLs. They're not intended to be placed that superficially. And so they can draw in water to the skin, which we know we're losing as a function of perimenopause and menopause, because you're losing water more, you're increasing that transepidermal water loss. So these gels are excellent for that.
So these things known as fillers by most people, you go into your physician, you get it. What's really we're recognizing here, and I think you'll agree with me, it's really important that they're injected properly.
Correct.
And when you're treating the menopause patient, it might be different than treating the young 35-year-old or 32-year-old who's looking for some sort of facial shape. This is different with the menopausal patient, how you inject it, and you really have to have a mastery of the anatomy as well as understanding the physiology of how to improve someone's appearance who's going through menopause, who has transepidermal water loss issues, or who has more wrinkles that are superficial, and you want to target those adipose-derived stem cells.
Right. So these are like some of the things I do in that young 40-year-old, right? And I'm probably doing it like once a year to kind of protect the health of the skin and really allow, them to go into their 50s with optimal skin health. And then lasers, there's a place for those as well, because the heat that is emitted by a laser that's not necessarily emitted by a microneedling device or by a chemical peel is able to stimulate the release of something called heat shock proteins. These heat shock proteins, hence the word heat, are only released through heat. And it has to be the right temperature. So you're looking at 60 to 65 degrees Celsius of heat in order to have them be evoked. Once evoked, they serve as chaperones so that the collagen and elastin that is created is laid down in a way that mimics healthy looking skin, not scar looking skin. And so that also is something that I think about. And I have my patients on a regimen where they're coming in for a skin cleaning every 6 months, just like you get your teeth cleaning, you get your skin cleaning. And by doing so, you retain that youthful glow, dewiness, skin turnover, and moisture retention that you would see in somebody who's 32 years old.
Now I want to pipe in here as a plastic surgeon, and I'm doing facelifts. I also like to have them on the HRTs or making sure their skin is optimized, because if I, just pull their skin back, so to speak, or pull their tissues back and I tighten them down, I want them to stick.
Yes.
And it's, in my experience, the more laxity that happens as they start to age and go through menopause, it's harder for it to stay in place. And I think they get more rebound. So the thicker their skin. So such things as HRTs are helpful. And then there's a whole the argument and the controversy over, if you do these biostimulators, do you cause a problem? Or these laser treatments, is it more difficult to get a facelift? And I can actually argue the opposite. Sometimes I think I get a better result because I have a layer of thickness there that then sticks down a little bit better.
Right, there was a facial plastic surgeon that actually published a review on maybe like over 100 facelifts where they had previous injections with PLLA, if I'm not mistaken. I can't remember the surgeon's name. But he argued the same, that the quality of the tissue is actually more youthful. And so he can actually hold it better. He can throw a suture in. It doesn't just slide and glide out, and the skin doesn't just rip. And it's not just the skin, but even the SNAS, which is a network of tissue that's also created by fibroblasts. That might be thicker. So everything is repositioned more readily and holds better over time than if your tissue is more friable, like we see if somebody is not on HRTs or has not done any of these measures to really keep the skin of the thickness of their skin thick.
All right, you're the dermatologist. What do you recommend for topical skin quality? What measures? What should we be looking at?
Right, and so it's like, what's the baseline, right? I always like to, what's the gold standard? What is optimal skin? One that's dewy, radiant, devoid of dyschromia or unevenness. One that's not too red either, like we see in rosacea, but has a little bit of
a pink hue.
Of a pink hue. And one that's devoid of tumors or growths. And we've published on this with Kate Goldie, the metrics of assessing the 4 emergent qualities of the skin when looking at the skin. And so I like to do things, topical estriol is a consideration, or estradiol, if you're in this stage and you're not perhaps ready to do.
Now, this is not FDA approved topical estrogen replacements or bioidentical hormones.
Right. But there are some topical formulations. Now, again, I would have this under the guidance of your dermatologist.
I'm going to clarify, not FDA approved for skin quality. They're FDA approved for, I think, their vaginal creams, if I'm correct.
Well, there are some now that have been studied for the use on the skin.
Okay.
But their approval, I am not.
Yeah, I don't think they're
sure
FDA approved for skin
right?
quality yet. Yeah.
And, in one study that was done that has not been published yet, they found that there was improvement in metrics such as dewiness, radiance, in lines and wrinkles after about 12 weeks of use when comparing estriol 0.3% to estradiol 0.1%. Now, what are the side effects sometimes of doing this is that you can have increased vasculature and redness, which we see with the topical estrogens. And so that's, if you already have rosacea, that may not necessarily be what you want to do.
And systemic absorption, is that a concern in your opinion?
In this particular trial, they did not see systemic absorption from the proper topical use on the face, not the whole body, right? And so that's a potential that I engage with when I discuss and counsel my patients. Now, there is some trepidation, especially for that perimenopausal patient who's like in her early 40s. She may not be ready for that, but she recognizes that there's a decline in the dewiness and radiance of her skin. And so that's where I really like the XOMD formulation, because it increases oxytocin receptors as well as binds to the oxytocin receptors at the level of the skin. And so that triggers a release of oxytocin that has a downward effect. And we know oxytocin receptors reside on fibroblasts, just like estrogen receptors.
And keratinocytes as well.
And keratinocytes, right? And so that's why we even see in wound healing trials that there's better wound healing from topical oxytocin. So there's definitely a role for that too. As we discussed in part 1, it's an interplay of all these hormones. It's not just one that has to do all the heavy lifting. And so I've seen, just like we saw in the trial, an improvement in radiance, dewiness, unevenness in tone without the increase in redness, which a lot of my patients like, because I see a lot of patients with rosacea. About 30% of my patients have facial redness. They're coming in for lasers for this. So the last thing they want to do is put something on topically that's going to make it worse.
So topical jasmine products, which have an influence on the oxytocin receptors, may be a good alternative option.
Especially for that young perimenopausal patient. And I think, and we'll probably see soon, that there might be an additive effect if you do it on folks that are already on HRT.
Now, it should be noted that oxytocin cannot get through the skin. The molecule is too big.
Right.
So the only way to administer it now is either IV or intranasally, but alternatives, like the ones that we've done research on, using jasmine as a way to stimulate the
phytopeptide that's extracted from jasmine, correct?
Yes, to stimulate the piezo-1 receptors, piezo-2 receptors, which are mechanoreceptors in the skin, which then upregulate oxytocin receptors.
And then what does that do? It draws in water into the dermis, which we know we're losing. That's the reason why the skin gets dry. So it's counteracting that. And so that's the reason why in the trial there was an increase in dewiness, radiance, and a more youthful glow. It's also anti-inflammatory, which there's not as much literature on topical estrogen to support, but oxytocin is anti-inflammatory, which is why we see a decrease in redness, in inflammation, which is one of the signs of aging as well, right? If you believe in the 12 hallmarks of aging, we know that inflammation is one of those hallmarks.
What about topical retinoids? Do you think there's a role for that?
That's another standard, right? There's nothing that's going to stimulate more collagen and elastin topically. So it's not just dewiness, radiance, increased water binding, and a decrease in inflammation, but we also want to increase collagen and elastin. And so there are retinoid receptors that topical prescription grade tretinoins can also bind to.
So it's not just skin, because lots of patients come in, their hair thins and maybe changes color, maybe starts falling out a little bit better, more so. What do you recommend there?
Well, there's a great study that's in a phase 2 at UCLA, some scientists out of UCLA that were able to actually give a drug that reversed some of these age-related changes we call androgenetic alopecia that we see with age. So, I mean, I think that would be the holy grail, right? But for now, what I like to do with my patients is do lasers, because you can have the most perfect face, but if you have like wispy, thin, brittle strands of hair that really frame the face, then it's still a visual cue of age. And so I like to use what now we've been using, the 1565 nanometer laser, non-ablative erbium. It's FDA cleared for the treatment of hair. And so we do 4 sessions, 1 month apart. And that has been able to show an increase in hair density of about 20 to 30%.
Do you still use it with the Cara Factor? Or?
So I do use it with the topical growth factor, Cara Factor, because these non-ablative lasers increase the permeation of the skin to be able to increase the absorption of some of these topicals. So you can do that. I also sometimes combine it with injectable PRP. There was a great study that came out from Brazil, Adriana Villarino, who did a combination of this laser with PRP and saw not only a thickening.
So PRP being platelet-rich plasma, where you draw someone's own blood, you spin it and take off the platelets from there and inject it, and you have a higher concentration of platelets and you put it back into the skin.
That are rich in growth factors and potentially some type of stem cells. And so she found an increase in the diameter of hair and then the density of hairs as well when you did this combination. So I like to combine both and I alternate those. There's also the 1927 nanometer thulium laser that is used for hair, and I use that as well. But I think recognizing that it's not just your hair, it's your face, skin, it's your nails, and preserving all of these things as you kind of go through this shift. If you're not necessarily ready for HRT, that there are topical creams that you can do, and you can obviously do the aesthetic treatments that we offer in the office.
Okay, great. So a lot of these things you're talking about are for women. Of course, I'm going to ask a little bit about men, and we should probably pivot a little bit towards men because we've talked a lot about women, and maybe there's a potential in the future to talk about men, and we can do a whole thing on andropause or
Menopause.
I like andropause, is a better word. It's something that it was unheard of when I was in medical school. It's like, what? Men don't have those. But in truth, there is probably some, I mean, we know testosterone levels drop in men as well, and some of the same symptoms women get, men can get.
Yes.
And hair loss, of course, is very common. More than 50% of men have lost their hair already by the age of 50. So where these treatments you're recommending, from the retinoids to the biostimulators to the hair treatments, do you think they're appropriate for men too?
I do. I treat a lot of men with, trying to preserve their hair, especially, that's such a visual cue of masculinity for a man as much as a jawline is, right? Of youth and strength. So I have men much younger than even someone who might be going into their 50s that are trying to preserve their hair, which is usually almost associated with higher testosterone levels, right? That hair loss. When
they're younger, for sure.
When they're younger.
So let's keep this for the next episode,
okay.
And let's wrap up with doctor's notes. So what recommendations, giveaways, or takeaways? What takeaways do we have from this episode that you think people can share? Pearls.
So I would say that these effects do not occur in a vacuum. Again, that there's a role for not just what your aesthetic provider can do for the wellness of your skin, both prescription with things like Retinoid or topical estriol, or even with some medical grade products like XOMD to supplement the hormonal health of your skin. But you can also start doing things like lasers for your skin and for your hair proactively. I like to recommend skin cleaning every 6 months. I'm in Southern California, so people have a lot of sun damage, and that just compounded when you go through these changes, hormonal changes.
So you're going to say start earlier.
So start early, so that tissue is optimized, that environment is, ripe and fertile well into your 40s and 50s, and you never experience a sharp decline.
Yeah.
That's what I would probably say.
So for Dr. Knows, I'm going to say that you have to see someone who knows what they're doing here, because it's different when you treat a patient who's perimenopausal or menopause than from someone who's younger or someone who's much older. And you have to adjust your treatments. You have to really understand the anatomy and the physiology, and as well as the products you're using and why you're using it. And it's just not something that's taught universally in our space.
And you have to, and then my third point is you have to see someone who will be honest with you and knows what they don't know. So when someone just says, I don't believe in that, or no, you want to be with someone who's open enough that they'll refer you to someone else if that's not part of their wheelhouse or their level of expertise. And that's okay, because they might be a really great expert at whatever they do, whether it's injections or lasers. But beware of the person that does all of it, right? The hormones too, and the nutrition and the GLPs, because they may not be an expert in all of it. And this is something that's very delicate and can really end up changing the trajectory of how you go into your 70s and 80s, where hormonal health can influence cardiovascular disease, bone health, as well as cognitive decline.
All right, one more doctor's note I want to add is that it's okay to talk to your doctor about it, whether they're male or female. You should bring it up with them. And up to 40% of women don't even bring it up to their providers. Maybe they're ashamed, maybe they're afraid, maybe they heard concerns about estrogen replacements. It's no longer taboo. It is part of our culture today. And there's so many treatments we have to alleviate the symptoms of menopause. Bring it up. It's worth it.
The days of having to deal with menopause is something that you're just supposed to go through are over. It's something that you could easily be able to manage and that you don't necessarily have to suffer through. And so bringing it up to your doctor so they can advise you, or at least send you and refer you to someone who knows how to hormonally optimize you, is what you should consider.
Fantastic. All right, well, you and I have dinner reservations and a baby to feed.
Yes.
So I think it's time for us to sign off today.
Okay.
And we'll be back soon with the next episode.
Thanks for joining us.
See you soon.